This is Handsome Nerd ASMR back with another video. In this video I want to talk about seizures, how they occur, why they occur, and what are the clinical signs and symptoms to diagnose seizures. So without further ado, let's get started. So a seizure is a transient occurrence of the signs or symptoms that are due to abnormal, excessive, or synchronous neuronal activity in the brain. And so the key features are that you can have a paroxysmal characteristic, so it involves sudden onset and limited duration. It can be reversible. So these excessive, abnormal, or synchronous neuronal activity can return to baseline unless it becomes complicated, and ultimately the seizure reflects the neuronal hyperexcitability and hypersynchrony. Another key point to remember is that a seizure does not equal to epilepsy. So in other words, it is not an epilepsy. This is because an epilepsy is a chronic condition that is defined by greater than or equal to 2 unprovoked seizures that occur greater than 24 hours apart, or one seizure with high recurrence risk. So the key phrase is unprovoked seizure. Alright, let's now dig into the neurophysiology and the pathophysiology. So, the normal neural signaling, it involves the balance between the excitatory neurotransmission and the inhibitory neurotransmission. The excitatory neurotransmission occurs primarily through the glutamate neurotransmitter, while the inhibitory neurotransmission occurs primarily through the GABA neurotransmitter. Mechanisms that lead to seizures are several. So seizures arise when this balance in neurotransmission is disrupted, and so it can result in increased excitation. So you can have excessive amount of glutamate being released, thus leading to upregulation of the N-methyl D-aspartate receptor, or the AMPA receptors. You can also have decreased inhibition, so there will probably be a GABA receptor dysfunction, or even reduced GABA synthesis or release. There is also going to be abnormal ion channel function, so there can be genetic mutations targeting the sodium and the calcium channels. This can lead to sustained depolarization and ultimately sustained neuroexcitability. And then you can have network synchronization. So this happens when large populations of neurons fire together. And then at the cellular level, you can have the paroxysmal depolarization shift, or PDS. This occurs through sudden prolonged depolarization and then a burst of action potentials followed by hyperpolarization. So that's the paroxysmal depolarization shift. Now let's classify the different types of seizures using the IOA framework. And so, first we have the focal seizures. They will originate typically in one part of the hemisphere in the brain. The first subcategory is the focal aware seizure. This was formerly known as the simple partial seizure. So in this type of seizure, the consciousness is usually preserved, and then the symptoms will depend on the cortical regions involved. So for example, if there's something abnormal with the motor cortex, so if there is, let's say, increased excitability in the motor cortex, there can be increased chronic generalized seizures. Because, after all, this is still focal in nature, because it starts focally, but then it eventually spreads through the corpus callosum of the brain, and that is why it is labeled as focal to bilateral tonic-clonic seizure. Then we have generalized seizures, where this time both hemispheres are involved from the onset of the seizure episode. So, the first subcategory is absent seizures. These seizures are sudden and brief, lasting about 5 to 10 seconds. They are accompanied by behavioral arrest or blank stares. There is no post-ictal confusion, and on the electroencephalomyogram, or the electroencephalogram, it can show the 3 Hz spike and wave appearance. And then it is often provoked by hyperventilation, and it is typically seen in children. So these are the important characteristics associated with absent seizures. We also have the tonic-clonic seizures. So, unlike the focal to bilateral tonic-clonic seizures, this tonic-clonic seizure involves the abnormal neurological activity affecting both hemispheres from the onset. And so, in this type of seizure, during the tonic phase, the patient will have sudden loss of consciousness and also sustained muscle contraction. So think about the muscle tone and the tonic. And they can also present with apnea and cyanosis. And then there's the clonic phase, where the patient will then present with rhythmic jerking and gradual slowing. Finally, there's the post-ictal phase to this, and this is when the patient will exhibit confusion, headache, and myalgia, or muscle ache. So, that covers the tonic-clonic seizures. Let's move on to talk about the myoclonic seizures. So for the myoclonic seizures, the patient will have sudden, brief muscle jerks, and then this will typically become worse in the morning. And then, unlike the tonic-clonic seizures, the consciousness is preserved. So that's the myoclonic seizures. Remember that the consciousness is preserved for this particular type. And then finally we have the atonic seizures. So this time, the muscle tone is lost, and it is lost in a sudden manner. So this can present with drop attacks or falls, and it presents with a very high risk of injury because of these symptoms. And so, don't confuse these symptoms with a situation where a patient feels lightheaded and suddenly, quote-unquote, passes out and falls to the ground, because that's going to be due to a syncope rather than a seizure. The syncope meaning reduced perfusion of the blood to the brain. Anyways, regarding the etiology of seizures, or the cause of it, you can break them down into 2 sense of fear or deja vu. And then the aura can usually occur in settings of a focal aware seizure. And sometimes it can even constitute a focal aware seizure. So just keep that in mind. And then ictal period is, or I should specify that the aura, it can let me double check something. Yeah, I mean technically it can occur in any type of seizure. Yeah, that's what I meant to say. Sorry about the confusion I just created. Anyways, we have the ictal seizure, and yeah, and then this is where there are motor, sensory, autonomic, or psychic phenomena involved. And this time, the duration of the seizure will usually last under 2 minutes. And then you have the post-ictal period, where the patient will then present with confusion, focal neurologic deficits like thoughts paralysis, and then even fatigue or headache. And then, sorry, I just received some text messages. But anyways, yeah. So pre-ictal, ictal, and post-ictal period. And really, the motor, sensory, autonomic, or psychic phenomena are due to the imbalance in the neuroexcitability and inhibitory features or aspects of the nervous system in the brain. So, now that you know the different phases of the seizure, let's talk about how we can diagnose or make an accurate diagnosis of seizures. So, the most important aspect is patient history. Pay attention to how the witness describes the patient's symptoms during the seizure episode. Note any precipitating factors for the seizure. Note the duration and recovery. And then the differentiation. Make sure to differentiate this from syncope or psychogenic events. And then you'll use the electroencephalogram. These can monitor for interictal epileptiform discharges. So this will happen during the ictal period. It can look for spike and wave patterns. But on the other hand, remember that the normal electroencephalogram does not exclude epilepsy. So just remember that and keep that in mind. And then for neuroimaging, MRI is usually preferred because it can better localize or track the structural lesions or defects that may have provoked a seizure, or at least caused a seizure. And then in acute settings, a CT is more practical, especially in cases of trauma or hemorrhage. And this is head CT, by the way. And then for labs, you can order for blood glucose and electrolytes to check for any metabolic abnormalities. Because remember that hypoglycemia can provoke a seizure. Same thing with decrease in sodium and calcium levels. guys. I hope to be back with more relaxing and educational ASMR videos like this. Please take care in the meantime. And yeah, until next time.